All right, next up for us is blood vessels. Recall that we're starting AP2 with the cardiovascular system, which includes the heart, blood vessels, and blood. We're going to skip over blood and do immune next, even though we should probably do these three systems together. The reason we're skipping over blood temporarily is because immune's tougher, and we want to get to the tough stuff at the beginning of the next module, and then we'll come back to blood. The thing that I would say about blood vessels is that there's a lot of low-level information here, but not a lot of higher-order thinking, which is great coming off the heart where there are all kinds of complex things like action potentials. I do want to remind you again that I'm trying to pitch the idea that we don't just learn at the lowest levels of remembering. I'm trying to push you to these mastery skills, which are critical thinking, simplify complexity, and realize there's a connection between form, function, clinical testing, clinical care, pharmacology, and pathology. And so let's take a look here again. There's higher order Bloom's concepts when it comes to blood vessel structure, so out here in purple, when it comes to blood pressure especially. Everything else is kind of simple and low level Bloom's, but do always try to push yourself, especially if you're interested in a particular area, to those mastery level skills, because I think those are the skills that are necessary to be successful in your program courses. Thinking about mastery. We're not just learning facts, we're learning skills and the skills to be able to master a subject. First note, the major areas: structure of blood vessels, blood flow, blood pressure causes and blood pressure through the circuit, edema, and then anatomy, specifically the names of various arteries and veins. As usual, we'll start with intro slides. This is actually a picture of the lungs, but it shows how densely blood vessels can be packed together. One of the most important concepts with blood vessels is to know that you don't have enough blood to fill all of your blood vessels at the same time. You have to move blood around to where it's needed, moment by moment, which means it's really complex to maintain blood flow and pressure. And while in modern society we think about high blood pressure as the major concern, low blood pressure is the biggest concern evolutionarily, because if you lose blood pressure, you faint, you die, you get eaten by the lion, so to speak. So there's a finite volume of blood, and you have to be able to move it around. I think about this moving blood around in the metaphorical sense of heating a house. My wife and I are cheap, and when it comes to heating our house, we use small space heaters to heat the room we're in, rather than heating the entire house by setting the thermostat to 72. We set the central thermostat to 55, and then we heat wherever we are. The metaphor is that we move the heat around the house, rather than fill the whole house with heat. Your body moves the blood around the body, rather than filling the whole body with blood by filling all the blood vessels. We move the blood around to where it's needed, just like my wife and I move the heat around to the house where it's needed. While the space heater strategy is much more efficient at moving the heat around the house, it requires more thinking and control, because if you haven't moved the space heater where you are, you end up getting cold, especially if that's in the middle of the night. Again, in this metaphor, blood is like heat. It's much more efficient to move a smaller volume of blood, heating where you need it with space heaters, than it is to have your blood fill up all of your vessels at the same time, heating the whole house. Fluid is heavy, so you might weigh upwards of 100 pounds more to carry enough blood to keep you filled up. But this means it takes remarkable control, because if you don't move blood to the brain when you need it in the brain, then the brain is going to suffer. You kind of already know examples of how the body moves blood around from learning about the autonomic nervous system in AP1. I'm sort of a visual person, and so I like to use pictures. A picture of a dog represents fight or flight to me, or a spider represents fear as well. In these situations, we move blood to the heart and to the muscles, while we also restrict blood to the skin and digestive system. You don't need blood at your digestive system when you need it at your brain to think your way out of this problem. We mobilize blood and energy to the systems that save us at the moment. A turkey, to me, represents Thanksgiving, and Thanksgiving represents rest and digest, parasympathetic nervous system. So here, we move the blood away from the muscle, out to the skin and to the digestive system. If you're exercising, over here, you move blood to the place where the blood is needed. So if you're doing deadlifts, you send the blood to your legs and arms. I like to mountain bike. I like the way my brain has to process information at different levels to account for impediments that are at different distances. So for example, up close, you have roots, and you don't want to go over your handlebars because you ran into a big root. There's trees within feet, and then you want to look up the path too to plan your next couple of turns. The more you work your legs though in mountain biking, the more it pulls blood away from your brain, and then you have difficulty processing things and you start crashing. So you pull blood away from your brain, and then you can't process as well, and so you start running into things. Other examples: if you're cold, you send blood down to your core to preserve heat, If you're hot, just needed a picture that indicated someone that was hot, you send blood to your extremities to get rid of the heat. Again, you move the blood around. We have to control blood pressure really closely because we don't want to lose consciousness. This is our typical homeostatic diagram. We're trying to control the variable in the middle. When the variable gets too high, we enter the top loop. When the variable gets too low, we go around the bottom loop. You don't have to memorize this yet. You will have to memorize this when you get to the urinary system. And I don't know if I've mentioned this before, but the urinary system is the most difficult system in AP2. My typical pitch is that you want to look for the big picture. You want to look at things from the right angle. Again, the right angle, at least in my opinion, is pathology. Cancer is an interesting one. It's estimated that one cancer cell develops in your body per day, where a cancer cell is a cell that's not following the normal rules of division. It's too young. It's touching somebody else, so there isn't room for it to divide, and it shouldn't be dividing if it doesn't have room, or the cell's DNA is damaged. If the cancer cell can get a food source from a blood vessel, then it's going to be much more likely that that cell is going to outrun the immune system. The immune system tries to kill abnormal cells, and cells become abnormal when they're too busy replicating themselves to make themselves normally or to repair themselves. So cancer appears to be related to blood vessel formation, and that increased blood vessel formation will increase the likelihood that the cancer cell will outrun the immune cell. This is why herbals like ginkgo biloba are not really recommended anymore, even though they seem to improve memory. They improve memory because they improve blood flow and blood vessel formation in the brain. Even conditions like sleep apnea may increase the risk of cancer because the body makes more blood vessels to cope with the decreased oxygen. So get that person you know who's not wearing their sleep apnea masks to take their sleep apnea or breathing disorder seriously, because if you don't get enough oxygen, your body responds by growing more blood vessels. If you have a cancer cell and you have more blood vessels growing, it's more likely that that cell will get a food source and outrun the immune system before the immune system says, hey, that cell doesn't look right, I better kill it. Of course, atherosclerosis is hardening of the arteries. Inflammation is when fluid leaks out of arteries. A thrombus is when a blood vessel is blocked by a clot. An embolism is when the clot has broken loose and it's going to block a blood vessel. Maybe look up some of these pathologies again if you want to give yourself a jump start on the pathologies you'll probably have to cover when you're in nursing. If you're not going into nursing, there's still value in seeing the connection to pathology for understanding your own health, because you might unfortunately have these conditions in your life or in the lives of your family. When you look at things from the right angle, things sort of come together in AP. So this is the wrong angle and this is the right angle where these lines come together. Looks kind of three-dimensional. Looks like a big picture. Here's an infographic that introduces anatomy and physiology, so a lot of physiology, and the pathology, so pathologies are in orange. So as with the previous infographic on the heart, the star structures in here link physiology to potential pathologies. Going to go over here and start with structure of blood vessels. So we'll start with the anatomy of blood vessels. This is on your own content we don't lecture in class, but you'll want to listen to or pull from the PowerPoints or the Prezi yourself. As is written here, the three major types of vessels are arteries, capillaries, and veins. Arteries, capillaries, and veins. Arteries carry blood away from the heart, veins carry blood toward the heart, and capillaries contact tissue cells and directly serve cellular needs, so they feed cells. Arteries and veins are composed of layers or coverings called tunics. The tunica intima, also called the tunica interna, is the innermost. Then the tunica media is the middle, and the tunica externa is the outermost. The lumen on the inside is a central blood-containing space surrounded by the tunics. In this image, you can see the layers labeled, and you can also start to see the differences between arteries down here and veins. So start to look at the differences. Is the tunica intima the same in both? Is it different? Is the tunica media the same in both? Is it different? How about the tunica externa? And then also note the size of the lumen, the difference in the size of the lumen. I would encourage you to try to see the pattern and what layer does what, because this pattern exists throughout the body. The internal layer, whether we're talking about the digestive system, blood vessels, or the heart, is specialized. The next layer is often muscle, and the outermost layer usually provides strength. Again, whether we're talking about blood vessels, the heart, digestive system. So the inside of the blood vessel has to be smooth. And the inside of the heart has to be smooth. The inside of the digestive system has to absorb nutrients. That's its specialization. Again, the inside layer of a blood vessel is specialized. In the case of the tunica intima, it's smooth. So the tunica interna or the tunica intima is an endothelial layer that lines the lumen of all the vessels. They're simple squamous cells, and they make things smooth to reduce the friction of blood flow. Simple squamous lay nice and flat, so they have a nice flat surface. Tunica media is composed of smooth muscle. This smooth muscle can change the size of blood vessels, especially in arteries. They are also elastic fibers, shown here in blue. They're not really shown on here, but they're present definitely in arteries, especially a certain type of artery called an elastic artery has collagen in it, so there's collagen fibers. Remember from AP1 that you basically have 3 different types of fibers: reticular fibers, which are kind of a net, elastic fibers, which are stretchy, and collagen fibers, which are strong. Tunica externa has lots of collagen fibers, and collagen is strong. Just to remind you, I guess I just said that. Reticular fibers make a net. They're usually in lymph nodes. Elastic fibers are in your ear and in elastic cartilage, and so they're stretchy. Collagen fibers are strong, and they're anywhere you need strength. Lining blood vessels in your skin or in cartilage between your vertebrae has a lot of collagen to make things strong. Side note, do you know what vitamin you need in order to make sure that you have plenty of collagen? The hint is it starts with the same letter as collagen, vitamin C, which is the correct sequence of layers in the vessel from outside to inside. So outside would be externa, media, tunica interna. So I like C. What do you notice? When you look at these, what are some of the different things you're seeing? What are the similarities and what are the differences between arteries and veins? Arteries tend to have a smaller lumen, and they have more muscle. And in most images that I see, they have a larger tunica externa to add strength, although you'll see various sources that say veins have a thicker tunica externa because they don't have the same amount of tunica media. So if they don't have as much muscle, then they need strength somewhere else, and that's the tunica externa. Arteries also have more collagen and elastic fibers. Veins are very collapsible because they don't have to deal with high blood pressure. We'll see this later, but the blood pressure in veins is usually below 15 millimeters of mercury, as opposed to arteries that have to deal with 120/80. Choose all the logical choices. Veins have a large lumen to deal with a large blood. I don't like large blood pressures there. Veins need a thick tunica media. Well, no, they don't need to change their size a lot, so that's not correct. Tunica interna serves different purposes in arteries and veins. I don't like that. The tunica interna has to be smooth. Arteries need a smooth inner surface. Veins need a smooth inner surface. Both of them have a tunica interna that's smooth. I guess we're at D. Keep drawing, DJ. Go! Purpose of the tunica interna is to be slick. That's the same in veins and arteries. I like that one. Arteries will need a thicker tunica media to deal with high blood pressure. Muscle is strong. I do like that one too. Veins have a big lumen because they're low pressure. That one's true. So yeah, that one's A, B, and C. So yeah, that one would be not a real multiple choice question, or it would be an all choice, or I need a D, all of the above, but all of those are true. Which tunica would enlarge with high blood pressure? The tunica intima, because it's right next to the pressure. That's not true. Its main job is just simply to be smooth. Tunica externa, because its job is strength. That's a good answer, and it's arguable, but if this was an NCLEX question, that would not be the best answer. The tunica media, because it's made of muscle. Muscle's really good at responding to strength by increasing its size. That's true. When you work your biceps, when you work your guns, they'll get bigger. Muscle's a very adaptable tissue, and so you might think tunica externa, because that's a good answer, but it's not as adaptable as just growing more muscle. And so here's some pictures too. There is some evidence too that perhaps you could diagnose chronic hypertension by looking at the thickness of things like the carotid artery. So this is just a brief citation that shows how the tunica media can change in chronic hypertension. So thickening of the tunica media could be used as a diagnosis for chronic hypertension. Getting ahead of myself a little bit today. Guess I'm a little excited about this one. These are just nice figures that show the different types of arteries, veins, and capillaries. So arteries, elastic arteries we'll get to, muscular arteries we'll get to, then arterioles, different types of capillaries, different types of veins. We'll go through all of these now, starting with arteries. So, structures of arteries. You have 2 types of arteries in your body, and unfortunately they both have 2 names. Both of them have 2 names. You have conducting arteries that are also called elastic arteries. These arteries come right out of the aorta, or they're the big arteries, so they're the larger type of artery. These arteries need to be elastic because they need to stretch under the high pressure of the heart pumping. They're going to see the highest pressures because they're closest to the heart. I think of these guys also, I think a lot in metaphors, as highways. So just like highways move a lot of vehicles, the conducting arteries carry a lot of blood. Distributing arteries, or muscular arteries, are more like the city streets and neighborhood streets. So they start once the big blood vessels split. Distributing arteries have muscle to change their diameter and alter blood pressure. So they can direct blood around. So when you're running away from a big dog, it will direct blood to the muscles and not to the skin, to the heart and brain and not to the digestive system. So distributing arteries are key in regulating blood pressure and flow. Here you can see the difference in the structure between conducting or elastic and distributing or muscular arteries. So conducting arteries have to be strong, so they'll tend to have more tunica media because, again, muscle is adaptable and can easily add strength by simply getting stronger when it feels more stress. And then muscular arteries would have less of a tunica media. A little more detail, elastic or conducting arteries are near the heart and have a large lumen for low resistance. These vessels contain all three tunics, and they need to withstand and smooth out the large pressure changes as the heart contracts and relaxes so that blood flow is fairly continuous through the rest of the vessel system. Muscular arteries are also active in vasoconstriction and relaxation, so dilation, to control blood flow and pressure. So if you apply the principle of complementarity to elastic versus conducting arteries, remember the principle of complementarity is how can we figure out how something works, the physiology, by analyzing how it looks, the anatomy. So anatomy relates to physiology. How something looks tells us about how things work. How do you expect things to be different between elastic and muscular arteries? It can be a little tricky here because the body might not always use the most logical thing that we think. So you do not expect the tunica interna to change because both types of arteries need to be smooth on the inside. Here, though, it gets a little confusing because the body could make the tunica media bigger and muscular, or it could make the tunica externa bigger in elastic arteries, but rather than making the tunica externa change, what it mainly does is when you need strength in the elastic artery, you have a thick tunica media. And then since you don't have such a thick tunica media and muscular arteries, you have a thicker tunica externa. So both of those can provide strength. Muscle actually provides a little bit more strength because it's adaptable. What layer of blood vessels is innervated by the sympathetic nervous system? Now this one's a tricky one because you got to go back to your AP1 and you got to remember something called tone. Tone was a part of the sympathetic nervous system that regulates blood vessel contraction. If we care about sympathetic tone, changing blood vessel diameter, then clearly we care about muscle. So I'm trying to think through this question before I even look at the options. A, sympathetic nervous system cares about muscle, therefore it's the tunica media. I like that one. Sympathetic nervous system strengthens blood vessels, therefore it's the tunica externa. I don't think the sympathetic nervous system strengthens blood vessels. It changes the size of them. Tunica interna, I'm going to stop right there because the tunica interna doesn't really change. So that takes me back to A. The sympathetic nervous system moves blood around for fight and flight, rest and digest. To move blood around, it has to widen some vessels, constrict some vessels, so it has to innervate the muscle. So the sympathetic nervous system innervates muscles, and therefore it's the tunica media. If the tunica externa is for strength and the tunica media for blood pressure control, then elastic arteries will have a thicker tunica externa, and distributing arteries will have a thicker tunica media. I should be careful about that one because I don't know that that's actually true. That's the way we think it should be, but actually I think it's the other way around. And again, it's tricky because what the vessels can do is use muscle for strength or that tunica externa for strength. I pull these questions from other sources. I usually don't write them because I want to not have to defend them as my questions, so I don't know that that was a good question. Arterioles are the smallest arteries and they lead into the capillary beds. Because there is a significant narrowing going from arteries to arterioles, this is one of the primary sources of blood pressure. We'll learn that pressures arise when blood hits the wall of a vessel. That's how we get pressure. And that's how you get pressure in physics too. When something's in a vessel, whether it's a glass vessel or a glass jar or whatever, it's the molecules hitting the wall that create pressure. In blood vessels, it's blood hitting the wall of the vessel that creates pressure. So when vessels narrow, blood hits the wall more often, and this contributes to blood pressure. That was arteries. Capillaries is a little bit more dense. I've tried to summarize them all in a little table here, so we'll next turn to capillaries. They're shown in this infographic, if you're using that tool. Capillaries are the smallest blood vessel. They're made of the tunica interna, and that's one cell thick and made of simple squamous cells. Why simple squamous again? because simple squamous cells create a smooth layer, so it's just like the tunica intima everywhere else in other blood vessels. Red blood cells pass single file through capillaries. There are 3 types of capillaries: continuous, fenestrated, and sinusoids. I've made a table to show the capillary types, their permeability, where you'd find them, and why you'd want that particular capillary there. First, continuous capillaries are used when you don't want a lot of permeability because you don't want a lot of fluid leaking out. You don't want leaking vessels in the brain because astrocytes are supposed to choose what in the blood reaches the neurons. Recall that was the blood-brain barrier. You wouldn't want leaky capillaries because then your blood-brain barrier wouldn't work very well. You have so many capillaries in your skin and muscles that you can't have them being leaky, and so that's why you have continuous capillaries there. Next, you might want some permeability where you want to get things out of the blood or into the blood. For example, you might want to get nutrients into the blood from the small intestine, or you may want things to come out of the blood in the kidney for filtration. In these cases, these are fenestrated capillaries, and they allow some leakage. If you want lots of fluid to come out of the capillary to process the blood, then you have sinusoids, so they have large holes. So in the liver, you need fluid to come out of the blood so that the liver cells can process the blood. In bone marrow, you need to get newly made blood cells into the capillary. Or in lymph nodes, you want fluid to flow slowly so white blood cells are able to act on anything that might be in the blood. So in that case, you want to be open, wide open, to allow more processing of the blood. We'll go through these in a little bit more detail, even though I think the table outlines things pretty well. Continuous capillaries are abundant in the skin, muscles, and brain. Cells that make the vessel are tightly packed together, and they don't leave much room to leak. This allows the astrocyte to be the blood-brain barrier, and it makes sure that not a lot of fluid is leaking out of the many capillaries that are in muscle and skin. Just a close-up picture of the continuous capillaries, notice that there aren't that many holes, which is hard to see until we look here where you see some holes. So fenestrated capillaries are found where fluid needs to flow out a little bit, as in the small intestine and kidneys. Another one that wasn't on the table was the fenestrated capillaries are found in endocrine organs, so hormones can be released into the blood. So remember, endocrine organs released chemicals into the blood. That's the definition of a hormone. Larger holes in the fenestrated capillary, at least compared to the continuous. Larger holes still here. Next is sinusoids. These are used when lots of fluid needs to come out of the capillaries or large things need to get into the capillary. An example is in the liver, where hepatocytes process the blood to store vitamins, filter the blood, or put things into the blood like albumin or clotting factors. These are things that are going to come up over and over in the class. Bone marrow also needs sinusoids, as there need to be larger openings to allow newly made blood cells, big things, to get back into the bloodstream. So you need large holes to get the blood cells in. Big picture of sinusoids. We'll end on the table. Just to review one last time: continuous, fenestrated, and sinusoid. They differ based on how much permeability. It determines where they are and why. Which of the following is true? Sinusoids are necessary in the brain? Nope, I know that sinusoids are not in the brain. Continuous capillaries are in the brain. The liver needs little circulation, being so dense, thus it's fed with continuous capillaries. That's kind of close, but we know that the liver needs to process the blood a lot, and so it actually needs lots of circulation. If skin did not have continuous capillaries, we need a whole lot more blood or a better lymphatic system. That's true. A little bit of a trick question there because we haven't gotten there this far, but the system that picks up fluid that's leaked out of capillaries and gets it back into the blood vessels is the lymphatic system. So if you had leaky vessels in your skin or muscle, you need a better system to pick up those leaked vessels, so you'd need a better lymphatic system. Next, we'll look at capillary beds. In capillary beds, there's 2 types of vessels. There are true capillaries, shown here in orange, that spread out and nourish the tissue. Then there's the thoroughfare, which is in yellow, or it's also called the vascular shunt, that carries blood right from the arterial to the venule, skipping the true capillaries. We'll see shortly that the ability to skip the true capillaries is how we move our limited quantity of blood around and save blood for where it's needed. So if you don't need the blood in this tissue, send it through the thoroughfare. It's going to get to the heart faster and back out to the tissue that needs it. If this tissue really needs it, send it out to the true capillaries and feed that tissue. A key to whether blood goes through the true capillaries or through the vascular shunt is something called the precapillary sphincter, shown here a little bit close up, and then these little pink structures here. Precapillary sphincter is made of smooth muscle that can close off the true capillaries so that blood goes through the shunt. The sphincters respond to nerves, oxygen levels, CO2 levels, lactic acid, and other metabolites. So it essentially senses what's going on in the tissue and whether that tissue is working at the time. If I can go back to the original heating metaphor, I like to think of the precapillary sphincters as a thermostat on a space heater. So when my wife and I could afford more expensive space heaters, we could set the temperature on the space heater, and the space heater would turn on and off based on that temperature, as opposed to the really cheap types of space heaters that just have an on and off. If you'd forget to turn on or off that kind of space heater, then you'd lose a lot of heat, or you'd lose a lot of energy one way or another. Or the room would get too hot and you turn it off, then the room would get too cold and you turn it back on. It was nice when the space heater had its own little brain. So in this case, the space heater, like I said, has a little brain that helps it control the heating. Precapillary sphincter is a little brain that helps tissue know where the blood should go, either through the true capillaries or whether it should be saved by going through the vascular shunt, where it will get back to the heart sooner and out to where it's more needed. So we move now from the anatomy of the blood vessels to control of blood flow, because it's related to those precapillary sphincters. 2 panels here to show the 2 possible conditions: blood in the true capillaries on the left, or blood going through the vascular shunt on the right. On the left, the tissue needs the blood, so the precapillary sphincters are open. On the right, the tissue is well nourished, so the precapillary sphincter stays closed, so that the blood goes through the vascular shunt and returns to the heart faster, again, where it can be pumped out to where it's needed. So on the left, precapillary sphincters are open because the tissue needs blood. On the right, the tissue doesn't need the blood, so the precapillary sphincters are closed and blood goes right through the thoroughfare or shunt. Precapillary sphincter is controlled by nerves, oxygen levels, CO2 levels, lactic acid, and other metabolites. Probably the simplest method in controlling this precapillary sphincter is if the local tissue is using up oxygen and ATP, there's no oxygen and no ATP to contract the smooth muscle in the precapillary sphincter. So the muscle has to relax without the ATP available, and so the sphincter opens. If the local tissue has a lot of oxygen and a lot of ATP, then there's plenty of ATP for the smooth muscle in the precapillary sphincter to have the energy to contract, and it keeps the precapillary sphincters closed. It's pretty elegant in its simplicity. So when you're in the gym and you're working the biceps, then the precapillary sphincters in the biceps open up to help nourish the biceps. Also, because the bicep muscle is using all the ATP and oxygen in the area, so there's no more oxygen and ATP for this precapillary sphincter muscle to contract and close. At the same time that you're working the biceps, down in the rectus abdominis muscles, they would have plenty of nutrition. They would stay closed so the blood goes through the vascular shunt, returns back to the heart, so it gets back out to the biceps again faster. So here, there's plenty of ATP and there's plenty of oxygen available because the rectus abdominis muscles are not using oxygen and ATP. The only vessel that provides direct access to nearly every cell in the body are the capillaries. The capillaries are what feed cells. One of the reasons humans have such big brains is that the nervous system has to control each capillary sphincter in the body. That's not true. That would be gazillions of precapillary sphincters. So it's nice that these precapillary sphincters can be controlled by themselves. They're controlled on their own. Probably not enough neurons in the world to control that many sphincters. One last tidbit is that they say a pound of fat has a mile of capillary. It's probably reasonably true. So this is why obesity can lead to high blood pressure, because you have to push blood through all those additional capillaries. Bring that up now because we're talking about capillaries. Veins. Venules collect fluid from capillaries and then join together to form veins. Venules allow fluid and the white blood cells to pass into the tissue. So here's where white blood cells can easily get out to the tissue and attack infections. I guess I said this before, but veins are formed by the convergence of venules. Veins are your capacitance vessels, which means they have the capacity to hold extra blood when not in use. You need more blood flow when you're stressed or when exercising, so you have enough blood to meet this need if you pull it out of your veins. But then when you're not stressed and you're not exercising, you need some place to store this extra blood. You store this extra blood. About 65% of your blood supply is in your veins at any given moment if you're not exercising or stressed. Veins have much lower pressure, as pressure is lost when blood passes through the very small capillaries. As said before, red blood cells pass through capillaries in a single file, so by the time you've gone through such a narrow vessel, you're not feeling the pressure from the heart anymore. Since blood in the veins is no longer feeling the pressure from the heart, blood needs to make it back to the heart using a different type of pressure. Those two pressures are the skeletal pump and the respiratory pump. The skeletal pump is created by skeletal muscles pushing on veins as the muscle contracts. Valves, shown here, ensure that when the blood tries to go this way, the valve closes, but when the blood tries to go this way, it returns back to the heart. So valves ensure that the blood moves back towards the heart. We'll see later that the respiratory system also helps. The respiratory pump is created when negative pressure in the thorax is used to draw in air during inspiration. So when you suck air in, that also creates a suction that pulls blood into the thorax from the outer areas. Still talking about veins, so I should mention this one exception. Very large veins are referred to as sinuses. Sinuses are flattened and large. Found in the back of the heart, we saw that as the coronary sinus. Another big one is in the dural sinus, so under the dura mater. Also the source of migraines, or thought to be the source of migraines. Which of the following conditions would not increase the chances of developing varicose veins? Okay, so varicose veins are when blood is trapped in the veins and it pools and it clots and it basically clogs up that vessel. So movement would decrease varicose vein production. 8-hour flights, I don't like that one. That's going to increase the chances. Pregnancy, yeah, you limit your blood flow when you're pregnant because you have all this extra fluid to feed the baby. Standing at attention for long periods of time, that one's definitely going to increase the likelihood of varicose veins because you can't move the blood because your muscles aren't moving. Running in place. Running in place is going to keep pushing blood out of your veins and make it less likely that they'll clot and form varicose veins. That's why you need to keep moving, especially on airplanes, not because you don't want varicose veins, but because you don't want blood to pool, and then you can get a thrombus. It's called deep vein thrombus when clots form when you've sat for too long. Get up on the airplane and move around a little bit. Another thing we need to cover before we leave the structure of anatomy and veins are anastomoses. Anastomoses occur where blood vessels diverge and converge and provide multiple pathways for blood to flow. So they split and then they come back together. True capillaries up here are an example of anastomosis. Another really important anastomose is at the base of the brain. Blood entering the brain enters the circle of Willis to be distributed around the various lobes of the brain. An artist's rendition might be a little bit easier to see. If blood flow is blocked in the circle of Willis, blood flow may still be able to reach all portions of the brain by going through an anastomose and around the blockage. So imagine right here that we have a blockage. Blood might be able to go around that blockage through the circle of Willis. So the circle of Willis is a pretty important anastomose. There's an anatomical variability in that not all people have something called the anterior communicating artery, this little one here, or shown over here. If there's a blockage of the anterior cerebral artery, which is this one, someone without the anterior communicating artery would kind of be in trouble because the blood could not go all the way around. So if this one was not here and there was a blockage here, no blood would flow to this region of the brain. That would be the right frontal lobe. But if you have the anterior communicating artery and a blockage here, the blood can flow around and you'd still have enough blood flow to both frontal lobes. So these anastomoses can be pretty important. How do you know if you have it? You don't. How can you increase the likelihood that you have it? Aerobic exercise. Aerobic exercise increases blood vessel formation. Blood flow. So we'll next talk about blood flow. Trick question. Besides the heart, what organ receives 100% of blood flow? You have different circulations with different priorities. For example, most of the blood leaving the left side of the heart is going to go to the kidneys. Blood leaving the gut does not go back to the heart. It goes to the liver first. See that here. And that's going to the liver because the liver does things like detoxifies things that are in your food. It stores vitamins and adds things like complement and clotting factors. The head and neck maintains flow very well so that humans rarely lose consciousness due to lack of blood flow. If I ask the classroom, raise your hand if you've ever lost consciousness, it's going to be about probably less than 25% of us have lost consciousness due to a problem with blood flow to the brain. The lungs respond to oxygen in a very different way than other tissues. It has to respond in the opposite way to other tissue. So low oxygen dilates blood vessels in the body to bring in more blood. So if you're working your biceps, oxygen levels are going down, you need to dilate blood vessels to bring blood to that area. If blood vessels in the lungs dilated in low oxygen situations, the blood would leave. The vessel is open further, the blood gets out faster, and so you wouldn't be able to load oxygen. So in the lungs, low oxygen causes blood vessels to constrict. This is also why respiratory disease stresses the right side of the heart, as the heart has to pump through these constricted vessels. So if you have untreated asthma, if grandma has bronchitis and she's not getting it treated, The blood vessels in the heart will constrict because they're having trouble picking up oxygen. They'll constrict so blood flow slows down and there's more time to pick up oxygen. But that is not very good for the right side of the heart because the right side of the heart has to pump blood through those constricted vessels, and that's how you can get hypertrophies on the right. Common theme in this class is how can the lungs affect the heart? How can the heart affect the lungs? Here's an example of how the lungs can affect the heart. Here's a breakdown of where the blood leaving the heart is actually headed to. So the answer to the trick question, of course, was the lungs. 100% of blood has got to go to the lungs eventually. Do note how much blood the kidneys are getting, so 22%. The kidneys are doing a lot, so they need to see a lot of blood. They're really processing your blood. They're taking out things. They're maintaining electrolytes and things like that. And I don't know if I mentioned this before, but the urinary system is the most difficult system in AP2. Any given time, up to 65% of the body's blood supply is found in. Trick question, because your brain might immediately go to veins. Then you start looking at the answers and you're like, veins is not there. So now you need to go back and remember, well, how are my tunics different in arteries versus veins to figure out which answer is correct? The vessels that also have a small lumen, well, arteries have a small lumen, and I was looking for veins. The vessel with a large tunica media, well, that again was arteries. Continuous capillaries, nope, that's not the answer. The vessels with large lumens, that does describe veins, so I like D. Control of blood flow. 5 to 6 liters of blood leave the heart every minute. Where it goes varies based on need. Long-term changes and where the blood flows is due to growth of new vessels. That's called angiogenesis. Short-term changes in flow are due to autoregulation. The two forms of autoregulation we'll cover, metabolic and myogenic. Myogenic will be very important when we get to the urinary system, and if you can memorize that now, it's going to save you something that you have to memorize later. And I don't know if I've mentioned this before, but the urinary system is the most difficult system in AP2. So it's better to memorize it now and have it as a recall later than having to relearn it or learn it then, because you'll be learning plenty of other things then. Blood flow through the tissue is important for delivering oxygen and nutrients and picking up waste products like CO2 and urea, providing exchange of gas in the lungs, absorbing nutrients from the digestive system, and then delivering waste products to the kidneys for removal. When talking about blood flow, we can talk about velocity of blood flow and the control, both short and long term. Additionally, blood varies by the area of the body. For example, blood flow to the brain is different from blood flow to the kidneys. It's different from blood flow to the lungs, which we've already kind of mentioned. But we're trying to break it down a little bit more. The speed of blood flow changes by tissue. Just as when you put your finger over the end of a water hose and the velocity of water speeds up as you make the hole smaller, the narrower the vessel, the faster the blood flows. Now, honestly, velocity is not a huge thing for us. Areas of the brain can control the flow of blood. For example, the sympathetic nervous system can direct blood to the brain, muscles, and heart. However, much of blood flow is controlled by the vessel itself. When a blood vessel controls its own flow, the term for this is autoregulation. And again, autoregulation is going to be important, and there's two main types. Autoregulation can occur in the short term or in the long term. Long term isn't going to be a big deal for us because that's growing new blood vessels. Short term is kind of important. Short term autoregulation is either via metabolic or myogenic control. And metabolic control, capillaries sense local metabolism to decrease flow. That's what we were talking about before. And I'm going to say this in the next slide, getting ahead of myself. With precapillary sphincters. In myogenic flow, blood vessel diameter changes with pressure to maintain a constant flow of blood. The key to myogenic control is to maintain flow despite changes in pressure. So again, we talked about metabolic control earlier when discussing precapillary sphincters. In metabolic control, if tissue is being used, blood will spread out through the true capillaries to nourish the tissue. If the tissue is not being used, blood will flow through the thoroughfare so that it will return to the heart directly to be pumped out again to tissue that may need blood. In addition to sensing oxygen and glucose, the local concentration of lactic acid, potassium acid, adenosine, histamines, kinins, and prostaglandins can signal the precapillary sphincters. In myogenic control, blood flow is maintained. And the reason I'm saying it that way is because we tend to think about blood pressure as being important, but in two very important conditions, to the brain and to the kidneys, blood flow is more important than blood pressure. If blood pressure decreases, the blood vessel will dilate to maintain constant flow. Now, we might think that blood vessel better constrict to get pressure back up, But if we care about flow, it needs to dilate. If pressure increases, the blood vessel will constrict to maintain constant flow. When we see that increased pressure, and if we're always thinking blood pressure, we think the blood vessel should dilate to get the pressure back down. But if a blood vessel dilated while it had increased pressure, you're going to get a lot more blood flow to the brain. That's not a good thing because you'll get cerebral edema. So both the brain and kidneys need a constant flow of blood. If there's not enough blood to the brain, neurons will die. If there's too much blood flow to the brain, cerebral swelling will occur. In the kidneys, a constant flow of blood is maintained even as systemic blood pressure might vary from a systolic blood pressure of 40 millimeters of mercury to 200 millimeters of mercury. So the flow stays the same. So in the brain and in the kidneys, we care more about flow than we care about pressure. So if we see a decreased pressure, we dilate because you need the same amount of flow, so you better open up this vessel since there's less push. On the other hand, if we have an increase in pressure, we might think that you should dilate, but if you dilated, you'd get too much push, and way too much fluid. So what you do is constrict. In that vessel, pressure is going to go up, but flow is going to stay the same. Long-term autoregulation occurs when additional blood vessels need to grow to maintain blood flow. Angiogenesis takes place as the number of vessels in a region increase, when existing vessels enlarge, when a heart vessel becomes partly occluded, or routinely in people in high altitudes where oxygen content of the air is low. You're going to grow more blood vessels. Again, there's more conditions that would cause this too, like sleep apnea. Blood flow regulation is different for different organ systems. We've been talking about this already. A little bit more specifics here. For muscles, blood flow is maintained by metabolic control, so low oxygen, high CO2, lactic acid, and other metabolites can signal vessels to dilate. Honestly, it's pretty cool because there's two types of epinephrine receptors in muscle. Beta receptors bind epinephrine easily and cause vessel dilation. So if there's only a little bit of epinephrine around, these vessels will cause dilation. Alpha receptors bind poorly and cause vasoconstriction. So it takes a lot of epinephrine to stimulate alpha receptors. What that means again is low activity leads to stimulation of beta receptors and dilation, bring in more blood. With too much exercise and too much activity, and now we've released a whole bunch of epinephrine, now we can bind to the alpha receptors and they cause vasoconstriction, which essentially sends the message you pushed it too much, so now we're shutting down. You're getting too much blood flow and we need to calm this down. You need to feel the acid to knock it off. So a little bit of activity, bring in more blood. Push it too hard, limit the amount of blood, so we shut this down. Both metabolic and myogenic controls ensure that the brain receives proper blood flow. So if you hyperventilate yourself, I'm not saying try this, CO2 levels decrease, blood vessels in the brain constrict, and that causes you to get lightheaded. So if you were to take 10 deep breaths right now, really deep breaths, you'd feel light, you'd feel faint-headed. It's probably also why things like meditation and deep breathing calms our brain, because we blow off CO2, and that actually constricts blood flow to the brain a little bit and calms our brain down. We'll talk about this later in respiration, but think also about how things like pain affect breathing, which affects CO2, which affects blood flow to the brain. So pain would cause hyperventilation. That's going to lower the amount of CO2, which lowers blood flow to the brain. So this one's a key one for the dental hygiene students, because when you cause pain, you're potentially causing hyperventilation. They're breathing off CO2. This is limiting blood flow to the brain. And it's kind of like, I don't know if this is true, the best way to describe this, but when somebody drinks alcohol, you don't really know how they're going to respond. Some people are very nice. Some people are very mean. When you cut off blood flow to the brain, you don't know how the brain is going to respond. And are they going to turn mean, or are they going to turn like super nice? You don't know. And so pain is kind of an important thing to monitor, because it does have this trend that pain affects breathing, affects CO2, affects blood flow to the brain. They might flip out on you if you're causing too much pain. Blood flow to the brain must be maintained with a mean arterial pressure, we'll talk about that, between 60 and 160. That 60 is a kind of key number, because anything below 60, again, we'll come back to this, is not enough blood flow. If mean arterial pressure is below 60 millimeters of mercury, fainting and damage to neurons can occur. If mean arterial pressure is above 160, fluid will leak out of capillaries, cause swelling in the brain. Note, the section of the brain on the left is swollen with excessive fluid. Given that the brain is confined by the cranium, the skull, Edema can lead to significant damage if the brain is swelling. So again, this is why blood flow needs to be controlled to the brain. Can't have it too high, can't have it too low. Blood flow through the skin supplies nutrients to cells in response to oxygen need. Helps maintain body temperature, so send blood out to your skin when you want to get rid of heat. Get it away from your skin and to your core when you want to maintain heat. When the body is warm, again, blood is sent to the skin to radiate. Body is cold, blood is sent deeper to maintain warmth. Skin also provides a blood reservoir to store blood when it's not needed. As the slide says, blood flow in the pulmonary circulation is unusual in that the pathway is pretty short. I don't have to go to the big toe and back. Just got to go to the lungs and back. Arteries and arterioles are much like veins and venules, so they're thin-walled with large lumens. They don't deal with high blood pressures. They have a much lower arterial pressure, so it's like 24/8 in the pulmonary circuit versus 120/80 in the systemic circuit. Blood flow to the lungs is, again, the opposite of other areas. So in your biceps, redundancy is good in AP2. In your biceps, if oxygen is low, the blood vessel will dilate to bring in additional blood. If that happened in the lungs, the blood would just leave the lung if the blood vessel dilated. In the lung, when the blood has low oxygen, the blood vessel constricts to give the blood more time to load and to send the blood to other areas of the lung where oxygen may be available. Yeah, you actually do move blood around in your lung, actually, to where the air is. We'll talk about that when we get to the respiratory system. Blood flow to the heart is limited while the heart contracts. Blood pools in the coronary sinus while the heart contracts. Then also you have something called myoglobin. It's a little bit like hemoglobin that carries oxygen in the blood that helps the heart store a little bit of oxygen because it can't get blood when the heart is actually contracting. Blood flow pathologies, so some terms. Circulatory shock is defined as any condition in which blood vessels are inadequately filled and blood cannot circulate normally. Shock results in inadequate blood flow to meet tissue needs and thus damage to the tissue results. The three main types of circulatory shock. Hypovolemic shock results from a large-scale blood loss. Vascular shock is poor circulation resulting from extreme vasodilation. Think anaphylactic shock. Cardiogenic shock happens when the heart cannot sustain adequate circulation. Blood pressure causes. First, let's explain the units of blood pressure, millimeters of mercury. A long time ago, scientists would take a glass capillary, shown upright here, and submerge one end in a dish of mercury, which has the elemental symbol of Hg. As air pressure went up and down, the mercury would rise and fall in the glass capillary, and they would measure how much it rose and fell in millimeters. Using that data, they could make predictions about the weather. So air pressure was measured in millimeters of mercury, and so that is used for blood pressure too. Keeping with the physics, the physical cause of pressure is when atoms or molecules are trapped in a container. When those atoms or molecules hit the wall of the vessel or container, this is what creates pressure. So hitting the wall creates pressure. So when things in the blood hit the wall of the vessel, that is the cause of blood pressure. Thus, anything that makes things more likely to hit the wall of a blood vessel will increase blood pressure. So if blood is thick, if it has a high viscosity, there are more things in the blood to hit the wall of the vessel, and that'll raise blood pressure. If the vessel is long, it's more likely that these blood cells will hit the wall of the vessel, so blood pressure increases. If blood vessel diameter gets smaller, things in the blood are more likely to hit the wall of the vessel and will increase blood pressure. So the three main things that cause pressure are blood viscosity, total blood vessel length, and blood vessel diameter. Another way of stating things is that if there's any resistance to blood flow, so that's where the term resistance comes in, things in the blood are more likely to bump against the wall of the vessel and increase pressure. So you'll hear the term peripheral resistance a lot to indicate things that cause rises in blood pressure. Of the three main things that can cause resistance, only one can be changed easily. So blood viscosity will not change rapidly. Blood vessel length will not change likely after you're 18 years old. Blood vessel diameter can easily change in arteries due to the smooth muscle in the tunica medium. Another good thing about changing blood vessel diameter is that due to the geometry, a small change in diameter will have a 16-fold effect on blood pressure. That's just the geometry. To review then, of the three resistances, only vessel diameter can be changed rapidly. A bonus is that small changes in vessel diameter have large effects on resistance. So if the radius is doubled, the resistance is 1/16 as much. Which of the following conditions will decrease the peripheral resistance? I'll give you a heads up already. This one's kind of tricky because anemia associated with a decrease in red blood cell count would make the blood thinner. So that would decrease peripheral resistance. Obesity, like we said a long time ago, would increase the amount of blood vessels because every pound of fat has an additional mile of capillaries. That would increase the peripheral resistance. Polycythemia associated with an increase in RBC counts. Don't like that one because the blood's going to be thicker. And dehydration. So dehydration means there's going to be less fluid, but it's going to be thicker. I think the best answer here is A, not only because dehydration is not a great answer, but clearly it's kind of got to be between A and C if you're good at taking multiple choice tests, because those are opposite things. It's got to be one of them. And it's anemia. So anemia sounds like a bad thing, and it is a bad thing, but at least from the point of view of blood pressure, though you have fewer blood cells, you also have fewer blood cells hitting the wall of the vessel, and so blood pressure is decreased. So at least it's going to flow better. You're going to have less blood, but it's going to flow better. When we talked about the autonomic nervous system, we talked about the various ways that the sympathetic and the parasympathetic work together. Often they oppose one another. In limited cases, in sexual excitation, they actually work together. Another possible interrelationship between the two systems of sorts is that only one system works. Blood vessel diameter is controlled just by sympathetic activity. There's no role for the parasympathetic system in blood vessel diameter. More activity will constrict the blood vessel. Less sympathetic activity will dilate the blood vessel. The term for this is tone, when only one system works. This is an important thing to understand physiologically because drugs that affect the parasympathetic nervous system may affect things like heart rate and contractility because both the sympathetic and the parasympathetic nervous system affects those. But since just the sympathetic nervous system controls blood vessel diameter, these drugs will not affect blood vessel diameter. Turbulence caused by plaques in blood vessels can further increase blood pressure, as the swirling of blood makes the blood more likely to run into the wall of the vessel. Just a cartoon diagram here where blockages create turbulence, but this one's a true one where this is a clot in the carotid artery, and as blood squeezes through there, it swirls more. And as it swirls, the blood is more likely to hit the wall of the vessel and increase blood pressure because hitting the wall increases pressure. So plaques increase blood pressure when they cause turbulence. Also, they cause turbulence when they narrow blood vessels. So another thing that contributes to blood pressure is plaque. Plaques embed themselves. So often we think plaques are in here. Plaques are deep in the wall of the vessel. So here's the plaque here. The lumen is out here, and the plaque is in the middle of the tunica media. Plaque narrows the blood vessel and makes it less flexible. Both factors increase blood pressure, both the narrowing and the loss of elasticity. Blood pressure through the circuit. Next, we turn to look at blood pressure as it flows through the different types of vessels shown down here at the bottom. Pressure declines throughout the length of the pathway. The steepest change occurs in the arterioles, and pressure is pretty low by the time you get out to the venules and veins, less than 20 millimeters mercury, down to 0 in the right atrium. When we talk about blood pressure, just a 120/80, there are two main bits of information we can get out of the 120/80. The pulse pressure is the difference between the two, in this case 40, and gives an idea of how elastic the arteries are. The bigger the difference, the stiffer the vessels. The amount of blood forced into the vessel is also reflective of how much force is needed to push blood into the vessel. So the 120, or maybe you have high blood pressure and your blood pressure is 180. The higher the number, the more pressure is needed. Going back to the pulse pressure, when blood is pumped into a not stretchy vessel, the blood pressure goes up a lot because the vessel can't stretch. So you get a high systolic. In a normal vessel, after you've pushed blood into the heart, the vessel will recoil, and that'll kind of keep the pressure up for a little bit, and it will smoothen out the changes in blood pressure as the heart beats and relaxes. But if the vessel is stretchy, it won't absorb that pressure, and it won't be able to recoil and put that pressure back into the blood vessel, so the blood vessel will drop a lot. So if blood pressure goes up really high and then down really low, it means the blood vessel is not very stretchy. Measuring blood pressure, Why would you care about the elasticity of a blood vessel? Could give you an indication of the amount of plaque in the vessel, because we said plaque makes vessels less stretchy. If the vessel is not elastic, then control of blood pressure will be diminished. To control blood pressure, a vessel does need to be elastic, be able to get bigger and get smaller. So C, both of these. We have various numbers that characterize arterial blood pressure. Systolic blood pressure is the high blood pressure when the heart is in systole. So in a blood pressure of 120/80, the systolic pressure is 120, and the diastolic pressure is when the heart is relaxing at rest, and that's the 80. Pulse pressure in green is the difference between systolic and diastolic. So in a blood pressure of 120/80, the pulse pressure is 40. Mean arterial pressure is a nice way to average blood pressure, although it's not a mathematical average. You can't take the mathematical average of systolic and diastolic because it will overrepresent the diastolic pressure. A metaphor is if you have a stack of gold in a pile like in this figure in the top right, and we measured the height, if we measured the full height, and I said you can have whatever on top of the orange line, that's half height, and I'll take whatever is below it, I'd get more gold. So this is just simple geometry, that you can't take half the height of a hill-like structure. To divide that pile equally, we would need to take a third of the height of the gold. Then the top and the bottom will be equal. So that's the pink line. So notice that the curve of arterial blood pressure is kind of hill-like. So we also can't take half height. We have to take a third of the height. So mean arterial pressure takes a third of the pulse pressure and adds it back to the diastolic pressure. So we take a third of the pulse pressure and add that back to the diastolic pressure, and that gives us a number that equally represents systolic and diastolic. The reason for that is sometimes it's easier to think in one number versus 120/80, 160/100. Here we're just listing out those pressures if you'd like to read them. Systolic pressure is the pressure during systole. Diastolic pressure is the pressure during diastole. Pulse pressure is the difference between systolic and diastolic. Mean arterial pressure is diastolic pressure plus 1/3 of the pulse pressure. Flip those around. 1/3 of the pulse pressure plus diastolic pressure. There are other ways to calculate mean arterial pressure. Like if you look it up, there's different calculations. So maybe what's the best thing to understand is just to realize that you want a number between systolic and diastolic that represents the two equally. I like 1/3 of the pulse pressure plus diastolic. Pulse pressure is somewhat diagnostic. As we said, pulse pressure reveals elasticity of arteries. It can also indicate things like blood is going the wrong direction through like the mitral valve. So if blood is being regurgitated through the mitral valve up into the left atrium, you won't get as high of a systolic pressure. Then you'll get a very low diastolic pressure. So this would cause a large pulse pressure. Again, one of the things that I would recommend in this class is to find some Wikipedia pages that are nice and simple to understand. The Wikipedia page on pulse pressure is kind of nice to read because it shows you all the things that can be diagnosed simply from taking someone's blood pressure and thinking, wow, the systolic is pretty high and the diastolic is pretty low. Stiff vessels will increase pulse pressure if the vessel can't stretch. It can't absorb pressure when the heart contracts and recoil to keep the pressure up when the heart is in diastole. So that would cause pressure to go high and then drop precipitously. Folate is thought to increase the elasticity of arteries and thus will decrease pulse pressure. Can't do it. As a dad and as a teacher, every time I see folate, I have to say this. If you're a young female that are a reproductive age and are sexually active, it's much easier to become pregnant than you think it is. You need to have folate in your diet because any woman that could become pregnant needs folate because the baby needs folate to complete the neural tube before you ever know that you're pregnant. A 1-to-1 relationship exists, for the most part, between spina bifida, when the neural tube doesn't close and the spinal cord is on the outside, and lack of folate. So if females that are reproductive age and could become pregnant are on folate, spina bifida would go away. So any female that's sexually active should be on folate. Another place where mean arterial pressure is going to be nice is in your AP2 research. Because mean arterial pressure is easier to plot than systolic over diastolic. So systolic over diastolic, you have two numbers. It's nice to plot one number in mean arterial pressure. When mean arterial pressure drops below 60 millimeters of mercury, there's not enough pressure to get blood to all the organs, and this may lead to organ failure. So it came up when we talked about the brain. A mean arterial pressure of 60 millimeters of mercury is kind of a key mean arterial pressure. Anything less than that indicates that you're not getting enough blood flow. Henniger has a BP of 160 over 100. His mean arterial pressure is, well, the pulse pressure here is the difference between the two, 60. What's 1/3 of that pulse pressure? 20. Now, 20 is not our answer. We need to add that back to the diastolic pressure. So that's why our answer is 120. So our answer is 120. Capillary blood pressure ranges from 20 to 40 millimeters of mercury. We'll talk about this later when we talk about how fluid comes out of capillaries and gets back into capillaries. You need them both. So in short, you have to have the right range of pressure because you want the pressure high enough to push fluid out of the capillaries to deliver oxygen and nutrients, but you don't want the pressure so high that fluid won't be able to get back into the capillaries to return to the heart. You need it high enough to get it out, but not so high that it won't come back in. We'll talk about that when we talk about capillary dynamics, fluid capillary dynamics, and it'll come up again when we talk about the urinary system, when we talk about edema. And I don't know if I've mentioned it before, but the urinary system is the most difficult system in AP2. Venous blood pressure, so down here when you get to the venules, is very low, usually between 20 and down to 0 millimeters of mercury. When you think of things as a physicist, the difference in pressure, having two pressures, is what causes things to flow from one place to another. Whether it's 20 versus 40 or 0 versus 20, you get the same amount of flow. So having blood pressure go to 0 millimeters of mercury means that you're only developing just enough pressure to get blood back to the heart without any waste. A little bit of a sidebar, if someone is cut and flow is smooth, so down here, as opposed to spurting, which would be up here, smooth blood loss means a vein has been cut. If the blood is spurting, then we're up here and an artery has been cut. Cut arteries are much more of a threat to life, obviously. We mentioned this briefly when we talked about veins. How does blood get back to the heart when the pressure is so low in the veins? We talked about the muscular pump, which is that skeletal muscles will push on blood in the veins and push the blood back to the heart. There are valves in veins that ensure blood goes back towards the heart and not in the opposite direction. In addition to the skeletal pump, the respiratory pump creates a low pressure that draws air into the lungs. This low pressure also assists blood in getting back to the heart. This is called the respiratory pump. This is just a close-up view of the skeletal pump. Recall that we'll always tie AP back to examples from pharmacology, pathology, clinical care, and clinical testing. An example of relating A&P to clinical care is to recognize that when someone is on bed rest, they're not using the skeletal pump to get blood back to the heart, and this can result in edema, so fluid in the extracellular space, fluid around cells. Serial compression devices are used to reduce edema by compressing the calves to mimic skeletal muscle contraction. Also, if you run a lot, these devices, as well as compression socks, will also reduce edema after a run. So, for example, I picked up some of these at my local stuff store for my daughter who runs cross country and plays soccer. And so after she's run for a while, she'll put on these compression devices to get the fluid back out of the calves to prevent it from getting more damage. So after you run a long ways, you'll have some muscle damage that will cause inflammation in the area, but then that inflammation will swell up and push cells apart and cause more damage. So you want to get that fluid out of there quickly after you've gone on a long run. You'll notice that if you see high performance athletes, runners often, they'll wear compression socks to prevent that fluid from ever building up in the first place. Next we'll do blood pressure control. Blood pressure is controlled by the heart, blood vessels, and kidneys under the supervision of the brainstem. So trying to be funny with the brain model. So the heart, blood vessels, and kidneys control blood pressure under the direction of the brain. 3 factors influencing blood pressure are cardiac output, which you've drawn, peripheral resistance, which is blood vessel diameter for the most part, and fluid volume. So how much fluid are you drinking and how much fluid are you losing? Blood pressure can be controlled by both short-term and long-term mechanisms. Short-term controls are cardiac output, like heart rate and stroke volume, as well as blood vessel diameter. Long-term controls are regulated by how much fluid enters the body, which is controlled by thirst centers in the hypothalamus, and how much fluid leaves under the control of the urinary system. So long-term mechanisms relate to blood volume, and we'll come back to these when we do the urinary system. I don't know if I've mentioned it before, but the urinary system is the most difficult system in AP2. In brief, there's direct renal mechanisms, which essentially come down to if there's more blood going through the kidneys. And then there's more urine being made to get rid of the extra fluid. If there's less blood, then there's less blood going through the kidneys, so less urine is made and fluid is retained. There are other indirect mechanisms like the renin-angiotensin system, aldosterone, and antidiuretic hormone, or ADH. We'll talk about thirst and direct and indirect fluid control by the kidneys when we get to the urinary system. And I don't know if I mentioned this before, but the urinary system is the most difficult system in AP2. So this is a figure from Wikipedia that essentially shows that correction of blood pressure involves changes in cardiac inhibitory centers, cardiac accelerator centers, and the vasomotor centers. So if BP is too high, baroreceptors are going to see that and increase their firing. What it's going to do is increase activity in inhibitory centers, decrease activity in accelerator centers, and it's going to decrease vasomotor centers to dilate blood vessels. When you decrease cardiac output and increase vasodilation, blood pressure drops and homeostasis is restored. If the opposite problem is decreased blood pressure, then the baroreceptors will fire less frequently. That will inhibit cardiac inhibitory centers, increase cardiac accelerator centers, and increase vasomotor centers to cause vasoconstriction, as well as increase cardiac output. That's going to raise blood pressure, and again, that's going to cause homeostasis. So the key things here are cardiac inhibitory centers, cardiac accelerator centers, and vasomotor centers under the direction of baroreceptors. These receptors constantly monitor the appropriateness of the current blood pressure and signal the need for change. A key receptor again, is the baroreceptor that's in the carotid up here and the aortic arch. There's other factors like chemoreceptors, high brain centers, blood-borne chemicals also provide feedback to maintain blood pressure homeostasis. Short-term mechanisms are maintained by two centers in the brain. The vasomotor center controls blood vessel diameter, and the cardiovascular center controls heart rate and contractility to determine cardiac output. If BP changes were always fast, all three systems would help maintain blood pressure. However, if blood pressure changes slowly, baroreceptors are fooled by the slow change. Which condition may fool blood pressure? So we're looking for what condition is going to cause a slow change, because that's what we're saying up here fools baroreceptors. Going for a run is probably not going to be a slow change. You're going to get a pretty rapid increase in blood pressure. Drinking 2 liters of water also, it may seem like that's going to take a while for you to absorb it, but you'll absorb 2 liters of water within a half an hour. That's a pretty quick change. Sepsis is a condition where you have a bacterial infection that damages capillaries and they start to leak, and they start to leak very slowly. And one of the problems with sepsis is blood pressure goes down so slowly that the baroreceptors reset and they lose track of the decreasing blood pressure. So sepsis, where capillary permeability increases gradually due to bacterial toxins. And again, it's something to look into because sepsis is an interesting condition where blood pressure falls slowly as toxins from bacteria harm blood vessels. When blood pressure is reduced slowly, baroreceptors and the vasomotor centers just reset and don't sense the decrease in blood pressure. So the baroreceptors fail to detect the lowered pressure. This is compounded by reduction in preload. Go back and think about that. We talked about preload as going down if you have blood loss, but it's also going to go down if fluid starts to leave capillaries due to sepsis. So the heart contracts more weakly. This is why sepsis can lead to lethal hypotension, because the heart doesn't respond and blood vessels don't respond to the decrease in blood pressure, and it leads to death. Measuring blood pressure. Most of you in the class have taken blood pressures before, but we'll still walk through it. We monitor blood pressure as a vital sign. The vital signs are pulse, as in heart rate, blood pressure, respiratory rate, and temperature. BP is measured with the auscultatory method. A sphygmomanometer is placed on the upper arm. Pressure is increased in that cuff to overcome systolic blood pressure, and that closes the vessel. When we close the vessel because the pressure is at 200, we don't hear any sounds. Pressure is reduced in the cuff until the vessel begins to open and close at systole. So when systole beats the cuff, the blood vessel will open and then close with diastole. And that's going to make a sound as the vessel opens and closes. It's going to sound like thumps. When we reduce the pressure in the cuff to diastole, now the vessel stays open all the time and the sound disappears. So as pressure is reduced in the cuff, the beginning of sound is systole and the end of sound is diastole. So in a little bit more detail, we measure blood pressure using the auscultation method with a sphygmomanometer. Essentially, you constrict the artery until no blood will flow. So you pump up the cuff to something like 200 millimeters of mercury. At that point, the vessel will be closed and there's no sounds. So the pressure in the cuff is greater than the vessel in the artery, so the artery has to collapse and close. Next, we reduce the pressure until the systolic pressure is stronger than the cuff. At this point, the vessel will open during systolic contractions and close during diastole. Since the blood vessel is opening and closing, you'll hear thumps. The beginning of thumps represent the systolic pressure. As the cuff pressure is reduced, eventually the diastolic pressure will be able to pass through the vessel. It will be bigger than the cuff. So when the cuff pressure is below the diastolic pressure, now the valve is open all the time, so we no longer hear thumps, and this is the diastolic pressure. So in brief then, the beginning of thumps is systolic, the end of thumps is diastolic. You can practice this on your own in lab or if you have your own BP cuff. So this figure from Wikipedia tries to visualize that here's the blood pressure, here's the cuff, and here are the sounds. So as the pressure in the cuff is reduced, it gets below the highest point of blood pressure here, and we begin to hear sounds. So this is the beginning of sounds when the cuff is equal to the highest systolic pressure. As the cuff pressure drops below the lowest blood pressure over here, the sounds disappear, so the end of sound is diastolic. So this would be systolic, this would be diastolic. Beginning of sounds, end of sounds. So these links, they don't work as direct links, and also I don't want to violate copyrights, but I'm directing you to these links if you'd like to practice hearing blood pressures. There's some unique ones too that demonstrate that auscultation is for more than just measuring blood pressure. You can also diagnose conditions like atrial fibrillation or valve disorders. Finding these pathologies with your ears is also why you should use your ears to measure blood pressure rather than just watching the blips in the blood pressure gauge. Your ears are more sensitive here than your eyes, and so make sure you use your ears when taking blood pressures. It's important to realize that blood pressure varies throughout the day. So down here we've got blood pressure throughout the day, sleeping, waking, arguments right here, stress, and things like that will cause changes in blood pressure. When we get to the urinary system, we'll see that the kidneys need to be isolated from blood pressure changes so that they don't make too much urine when blood pressure is high, or so that they don't stop filtering when blood pressure is low. I don't know if I've mentioned this before, but the urinary system is the most difficult system in AP2. So the more you can learn about this now, the easier it's going to be when we get to the urinary system. So factors that affect blood pressure include age, sex, weight, race, mood, socioeconomic status, which probably ties to diet a lot, and physical activity. Case study, we'll run through it really quick. Recall circulatory shock briefly is when there's not enough blood flow to meet tissue needs. You can have 3 different types of shock: hypovolemic, vascular, and cardiogenic. I'll let you read through this case study. So Robert Clark is a 20-year-old male who's recently been in a physical altercation. He received many lacerations. These wounds are now festering and warm. He appears very ill. He's unable to respond coherently to staff, and he appears pale and cyanotic, so he looks blue. Swelling can be seen in his extremities. The major symptoms to pay attention to are the festering wounds that indicate infection, coherence that indicates a lack of blood flow to the brain, cyanosis indicates decreased oxygen, and swelling indicates that fluid has left the blood vessels and is filling the extracellular space. Wounds that are festering and warm suggest an infection. What does the cyanotic appearance indicate? Again, kind of obvious. not enough oxygen. Why no oxygen? Bacteria are stealing all the oxygen. Inflammation, swelling suggests there's a lot of edema, including fluid in the lungs. He's too weak to breathe. I think it's probably B. If you've got edema and swelling, you probably have fluid in the lungs, which means it's harder for the lungs to pick up oxygen. So the blood that's being pumped doesn't have as much oxygen, leading to cyanosis. Coherence? Why would it be incoherent? Again, that's duh, Henniger. No oxygen means unhappy neurons. Why would you want to talk about blood pressure? One of the factors in cardiac output was the heart pumps faster when there's no oxygen. That was not one of the factors in cardiac output. If there's inflammation, swelling, and fluid in the lungs, that fluid is not in blood vessels. I like that. That's true. Blood pressure will be fine. Baroreceptors will take care of it. Well, we're leaning towards sepsis here because blood pressure will not be fine if you have fluid slowly leaking out of blood vessels. So Mr. Clark has... I'm trying to slip sepsis back in here. So again, in sepsis, you've got an infection. The immune cells respond, cause inflammation. That pulls fluid out of the blood vessels, and it also puts fluid into the lungs, and that can lead to death. Cardiac output is trying to change, but it's not being able to change because the baroreceptors are not telling the heart that blood pressure has changed. Plus, preload is actually going down. Pathologies of blood pressures. Hypotension is when systolic blood pressure is routinely below 100 millimeters of mercury. Hypertension is a sustained elevated arterial pressure of 140 over 90. Over the last few years, that number's dropped, and you're considered to have pre-hypertension at 130 millimeters of mercury. Transient elevations are normal and can be caused by stress, physical exertion, and fever. Chronic elevation can cause a number of problems, from vascular disease, renal failure, and even a decrease in intelligence. So get your blood pressure regulated, says the person that doesn't do that very well. There are different types of hypotension. Orthostatic hypotension, when a change in body position causes a sudden drop in blood pressure. Essentially, when someone stands up from a sitting position, they literally stand up out of their blood. Baroreceptors should sense the decrease in blood pressure and rapidly increase heart rate and constrict vessels to push the blood back up to the head while you are standing up out of it. When the baroreceptors fail, someone will stand up out of their blood and get lightheaded. This is common in the young, as their baroreceptors have not fully developed. This is also common in the elderly when baroreceptors age out and fail. Chronic hypotension is often tied to nutrition and often a lack of B vitamins to make the ATP necessary for smooth muscle in blood vessels to constrict. In acute hypotension, the cause is likely circulatory shock. So if you have low blood pressure, it's probably a lack of B vitamins. Primary hypertension is caused by diet, obesity, age, race, genetic stress, and smoking. If there's another cause of the hypertension, like excessive renin, like the adrenal glands are failing and overproducing this compound, or blood vessels are hardening, this is called secondary hypertension. Next, we're going to do edema. Honestly, I think edema is probably better to just go and watch these videos, but I'll talk it through here too. We next turn to fluid flow into and out of capillaries. We'll discuss the dynamics here since we're covering blood vessels. And when we get to fluid and electrolytes, we'll extend on this fluid flow to describe edema, a condition where there's too much fluid in extracellular space around tissues. If you can learn this well now, it'll make it easier to understand causes of edema when we get to the urinary system. And I don't know if I've mentioned this before, but the urinary system is the most difficult system in AP2. So it's better to learn this now, so you'll just be reviewing it then, rather than learning it all brand new then. Blood cells do not leave the capillaries, so red blood cells don't leave the capillaries. Fluid does. The fluid carries oxygen and nutrients out to the tissue and picks up waste products to be brought back into the capillary and deliver away for waste removal, like by the kidneys. Water-soluble solutes pass through the gaps in the capillary, while lipid-soluble molecules move through the membranes of the cells that make up the capillary walls. So here's just a more visual description of the movement of the substances into and out of the capillaries. So again, this is inside the capillary, this is outside the capillary. Blood cells are in here, and blood cells do not leave the capillaries, though fluid does. So O2 and nutrients will leave. The fluid carries oxygen and nutrients out to the tissue and picks up waste like CO2 to be brought back into the blood. Technically, there's two routes. Water-soluble has to go around the cells that make the capillary. Fluid-soluble waste products and things can go straight through the cells that make the capillaries. To understand how fluid enters and exits the capillary, we must review the forces that cause flow. So factors that affect these forces will contribute to edema. There are two main pressures that influence fluid entering and leaving the capillary. The first is hydrostatic pressure, or HPC, which is essentially blood pressure. Capillary hydrostatic pressure. Capillary colloid osmotic pressure, we'll shorten that to osmotic pressure, is when water moves towards a concentration of solute. So OPC is caused by protein made by the liver called albumin. The HPC and OPC change from the beginning to the end of the capillaries, so we need to keep track of four pressures: HPC and OPC at the beginning of the capillary, HPC and OPC at the end of the capillary. These pressures will also be similar to pressures that we will come back to when talking about the urinary system and how the capillaries in the kidneys do this. So if you can learn them well here, this will help you when you get to the urinary system. And I don't know if I've mentioned this before, but the urinary system is the most difficult system in AP2. So again, learn it now, so you're just reviewing it then, not relearning it or not learning it anew. So shown more visually, HPC is the pressure of blood against the capillary walls. OPC is the osmotic pressure created by this non-diffusible, so it can't leave, plasma protein made by the liver called albumin. The reason we mention made by the liver is that it demonstrates how problems with the liver, where you can't make albumin, can cause problems with the cardiovascular system. So liver failure will often cause swelling called ascites. We'll talk about that when we get to the urinary system. HPC at the arterial end is 35 millimeters of mercury, and it's pushing fluid out. OPC, the albumin is in the blood, so OPC is drawing fluid back in, and it's drawing fluid back in at 25 millimeters of mercury. So the net filtration pressure, where's the fluid going to go, is 10 millimeters of mercury out. HPC at the venial end drops to 17 millimeters of mercury out. OPC stays the same at 25 millimeters of mercury. The net filtration pressure differs now because now we're pushing out at 75, drawing back in at 25, so the math is negative 8 millimeters of mercury net filtration pressure. Or the fluid is out at this end at 10 millimeters of mercury and in at this end at 8 millimeters of mercury. So fluid flows out of the capillary at the arterial end and back into the capillary at the venial end. We'll come back to edema when covering fluid and electrolytes and the urinary system. And I don't know if I mentioned this. Hopefully you can complete that sentence yourself at this point. If not, you'll probably hear it another 40 times still. Sorry. So here are the videos that you could go, or just go to Henniger DJ on YouTube and look up edema. And just watch the beginning of the video, because we'll do the edema part when we get to fluid and electrolytes. But you might want to watch the beginning where it talks about HPC, OPC, and fluid flow. I'm not a huge fan of lecturing over anatomy because it ends up being a lot of pointing and naming, and I think you can do that in your own head in the following figures. In lab, you'll be given a specific set of arteries and veins that you'll need to identify on a cadaver or a human torso model. So the next few slides are simply anatomical diagrams of arteries and vessels. I'm going to flip through them, but do come back at the end, so don't just quit the video now because we're going to go through some mastery thinking. But also these are here because on the test, you also have to come up with 10 arteries and 10 veins on this first test. But again, in lab, we'll get more specific about arteries and veins that you should know. So arteries of the head and neck, arteries of the brain, upper arm, arteries of the lower limbs. So I'm thinking if you want to learn these, use these as a tool for that essay question on the test. Pause the video and look at these. But I'm going to keep flipping through them because I want to get to the mastery thinking stuff. Alright, so recall that when we get out to these purple circles, there's mastery thinking. Now I'm not going to go into detail in all of these, but there's some cues to some interesting things that you can study related to blood vessels. So explore pathologies associated with the structures of arteries and capillaries. This one's kind of a cool one. So there are cases where people make additional anastomoses that they shouldn't. So when we talked about anastomoses, they were a benefit. But if you get an anastomose here, that's kind of a bad deal because the blood's not going to go to the hand. It's just going to go from artery to venial. So that's kind of a bad condition. Or think about the fingertips as the last place to get blood. And so if there's something wrong with the fingertips, it can indicate a problem with blood flow. These are called clubbed fingers, and they often indicate a decrease in respiratory function or simply nutrition. The blood vessels in the fingertips are not getting enough blood. What blood vessels do when they have too much CO2 is they dilate. So the blood vessels in the fingers are dilating, causing fluid to swell, and the fingertips swell. And then this was the one I mentioned earlier. I think I gave you the answer. But you need vitamin C to make collagen, and collagen's pretty important. So if you have a vitamin C loss, you'll get small microhemorrhages, which, this is the fun word to say, petechiae. Petechiae is when you get small purple pinpoints because your blood vessels are leaked, because usually it's not enough collagen. Rank what circulations are most important to the head, the liver. How might conditions such as sleep apnea increase the risk of cancer? Why is poor nutrition, specifically usually a lack of vitamin B, a primary cause of hypertension? So why do we need B vitamins, and what do they do to maintain blood pressure? We'll come back to edema, but you could start to think now, based on HPC and the need for the liver to make protein for OPC, and how you don't want damaged capillaries for those capillaries to not leak. What are the causes of edema related to HPC, OPC, capillary integrity? And the fourth one that contributes to edema is when fluid leaks out of a capillary, it's picked up by the lymphatic system. So you can also get edema when there's failures in the lymphatic system. You can look up the term arterial gush, and then things like which arteries, when damaged, would be the most likely to cause a fatality. Which arteries are most exposed to external trauma? All right, so that's all for blood vessels. Thank you.